Interpreting an arterial blood gas, or ABG, isn't just about plugging a bunch of numbers into a chart. It is literally like stepping into a high-stakes cinematic medical thriller where your patient's life is hanging in the balance. Today, we're going to learn how to decode the clues hiding in the bloodstream, transforming what looks like a chaotic jumble of lab values into a crystal-clear, life-saving narrative. I absolutely love this quote from our source material. We are all trying to reach the truth. What is the problem in this patient? Think of this as the director's vision for our explainer today. Because despite all the intimidating math and complex algorithms, our ultimate goal as clinical detectives is simply to uncover the hidden truth of the patient's pathology. We're looking for the true story the blood is trying to tell us. Okay, let's dive into our strict investigation protocol. 1. The scene. 2. The primary suspect. 3. The accomplice. 4. The alibi. And 5. The case files. It's a simple structure, and if you stick to this script, you will never miss a vital clue. First up, step 1, the scene, assessing oxygenation. In any good movie, you have to establish the scene first, right? Before we even glance at the acid-base balance, we must secure that scene, because if the patient isn't oxygenating, literally nothing else matters. We evaluate this using the PF ratio. Normally, a healthy PF ratio is sitting comfortably between 400 and 500. But if that number drops below 300, cue the dramatic music because alarm bells should be ringing. Dropping below that massive 300 threshold indicates severe pathology. If you see this kind of hypoxemia alongside a bad chest X-ray, you're often looking at ARDS, or acute respiratory distress syndrome. It's a critical scene. Step 2, the primary suspect, pH and CO2. The scene is secure, so now we need to cast our main villain. We do this by looking at the blood's acidity and the carbon dioxide levels to see exactly which organ system is failing our patient. 7.4 is your absolute non-negotiable baseline for pH. In this investigation, there is no gray area. Anything below 7.4 firmly establishes the crime as acidosis. Anything above 7.4, that's alkalosis. This instantly tells us the fundamental nature of the metabolic or respiratory crime being committed. And here is how we profile that primary suspect. Just watch how the pH and the CO2 move. If they're moving in the exact same direction, so both up or both down, the primary suspect is metabolic. But if they're moving in opposite directions, kind of like a seesaw, you've got a respiratory offender on your hands. Moving to step 3, the accomplice, mixed disorders. Beware, because here is the classic plot twist. Our primary suspect almost never acts alone. One of the biggest mistakes you can make is rolling the credits early. We have to actively hunt for hidden accomplices, those mixed disorders lurking silently beneath the surface, wreaking havoc. To find them, we pull out our primary interrogation tool, the anion gap. By calculating the difference between measured positive ions, mainly sodium, and negative ions like bicarbonate and chloride, we can detect if an unseen, unmeasured acid has invaded the bloodstream. A normal gap is 12 or less. Anything higher, you've got an unmeasured acid on the loose. If that gap is elevated, we run this exact mathematical sequence to flush out the hidden accomplices. Step 1, find the delta anion gap by taking the patient's gap and subtracting the normal of 12. Step 2, take that extra gap and add it back to the patient's measured bicarb to find the corrected bicarb. And step 3 is the big reveal. If that corrected number is way over 24, surprise, they have an additional hidden alkalosis. If it's under 21, you've got an extra non-gap acidosis. Now for step 4, the alibi, checking compensation. We shift our focus to the body's defense mechanisms. We have to interrogate the system. If one part fails, is the other system genuinely trying to fix the problem, or does its alibi completely fall apart under scrutiny? Enter Winter's formula. This is your ultimate lie detector test for metabolic acidosis. If your patient has metabolic acidosis, their lungs should aggressively blow off carbon dioxide to compensate. This formula tells you exactly what their CO2 should be. If the actual, measured CO2 doesn't match this expected math, the respiratory alibi is totally busted, meaning there is a secondary respiratory crime occurring at the exact same time. On the flip side, if the primary problem is respiratory, we use the rule of 1, 2, 4, 5 as our decoder ring. Metabolic compensation by the kidneys actually takes time, so we have to split this into acute versus chronic scenes. For every 10-point shift in CO2, the bicarb will shift by 1 or 2 acutely, but 4 or 5 chronically. If the bicarb doesn't match these expected shifts, you definitely have a mixed disorder. Finally, step 5. Case files, cracking the code. Time for the third act climax. Let's transition from theory into the actual high-stakes application of our protocol using real patient cases from the explainer's source material. Here is our first evidence board. A 63-year-old man presents with generalized malaise. Look at these numbers with a sense of urgency. The pH is 7.32. That's severe acidosis. The CO2 is 24 and the bicarb is 12. They're both moving down, the exact same direction, pointing straight to a metabolic primary suspect. And wow, look at that glaring anion gap of 22.
So, applying the protocol, we have an acidosis, it's metabolic, and the gap is high. But what is the full, true disorder here? Is the respiratory system appropriately covering for it, or is there a hidden accomplice? Take a few seconds to deduce this yourself.
The diagnosis is high anion gap metabolic acidosis with full respiratory compensation. We know this for a fact because if you plug that bicarb of 12 into Winter's formula, the expected CO2 comes out to exactly 24 to 28. The patient's CO2 is 24. It matches perfectly. The respiratory system has a rock-solid alibi and is doing exactly what it's supposed to do. Now, brace yourself, because this next case is straight out of a medical horror movie. We have a sedated patient with a truly lethal pH of 6.88. The bicarb has plummeted to 7. The anion gap is 10, which is completely normal. But look at that CO2. It's sitting at exactly 40. This should instantly make the hair on the back of your neck stand up. Why on earth is the CO2 totally normal when the pH is at a lethal 6.88? With a bicarb of 7, Winter's formula demands that the lungs should be screaming, aggressively blowing off CO2 to get it down to around 16 to 20. Yet it's just sitting at 40. The alibi is completely destroyed. Here is the devastating plot twist. The diagnosis is a combined non-anion gap metabolic acidosis and a respiratory acidosis. Because the patient was heavily sedated with benzodiazepines, her respiratory center was totally suppressed. She physically couldn't blow off the CO2, creating a lethal secondary respiratory acidosis right on top of her metabolic crisis. It's a tragic iatrogenic harm. All right, let's look at our final, most deceptive case, the perfect crime. A 23-year-old man presents with vomiting. Look at the pH, 7.38, CO2, 41, bicarb, 23. Honestly, on the surface, these numbers look incredibly confusingly close to perfectly normal. It is so tempting to just send this patient home. But we're clinical detectives, right? We never stop at the surface. What is hiding underneath that normal-looking pH? I challenge you to look past the 7.38 and notice the glaring, screaming clue hidden right in the math. The anion gap is 22. Normal is 12. There is a massive hidden acid load here. And here is the epic final battle happening in his blood. When we calculate the corrected bicarb using the delta gap, it reveals a shocking hidden bicarb of 33. The true diagnosis? Diabetic ketoacidosis, causing a massive high-gap acidosis warring directly against a severe metabolic alkalosis caused by his vomiting. Two massive, lethal disorders pulling his pH in totally opposite directions, completely masking the true danger. And that is exactly why we rely on the protocol. So the ultimate question to leave you with today is this. Are you ready to look past the surface numbers and decode the cinematic truth hidden in your next patient's blood? Because by using this specific structured algorithm, you now have the ultimate investigative tool to confidently unravel absolutely any medical mystery you encounter. Stay curious, trust the script, and we'll see you on the next explainer.